Hey, good afternoon, everyone. I'm presenting on behalf of Caroline Ranke, my partner, who is unfortunately tied up today. So only disclosure for this slide is this work is funded by the SAGE's COVID-19 Research Grant Award. No other disclosures from any of the other authors. So kind of to go through here, obviously a lot of presentations and documentation and papers have been written about COVID and the effect in general surgery regarding to elective and non-elective cases. Within surgery itself, emergency general surgery was kind of unique in this time period because it requires the most time-sensitive management, and most of these procedures can't wait, like some of the other procedures that were delayed during these pandemic spikes. This has been seen across the board at multiple institutions across the world, from the UK to Australia, and everyone has pretty much the similar experiences. So we wanted to see how this impact was determined in a larger system, especially in our metro area, judging the fact that we have 7 connected hospitals there. So we had a study aim with 4 specific hypotheses. It was to evaluate emergency general surgery presentation across a regional healthcare system during the time frame of the COVID pandemic and compare that to our historical cohort. Our hypothesis number 1 was going to be there would be a decreased number of patients admitted with EGS diagnoses during that peak COVID periods. Hypothesis number 2 was there would be a greater disease severity in the patients that were presenting in these time periods, followed by 3 that our smaller hospitals would see a steeper decline in EGS presentations than our urban hospitals. And our final one was that patients with lowest income categories would make up a larger percentage of the emergency general surgery patients during those peak COVID times. So we delve into these. These are the EGS diagnoses we used. You can see appendicitis, cholecystitis, small bowel obstruction, diverticulitis as follows. We also use these and quantify these by the ASCT grade category and guidelines. So this right here is a look at our first graph kind of here. So we categorize our peaks at when the bar on the right, Atrium Health System COVID rate went over 8%, and that's what we considered our peak from there. The top line you can see is our EGS volume control group, and that's the group that we used pre-pandemic, and then followed shortly below it is the orange one, or I guess yellow maybe. That's the EGS volume group during the pandemic. You can see kind of right where this graph starts, the volume was the lowest, and you can see how it kind of trends up as the peaks hit. So if we delve into demographics here, not a lot of this was any different. Some things that we pointed out immediately and we found on kind of our initial demographics were the zip codes were something that pointed out in the average income. And those people, as you can see, that were in the highest income classes were actually more in the pandemic cohorts, which is, from one of our hypotheses, was the opposite of what we talked about or we thought was going to happen. If you look in here, this is kind of the split of who presented from this. The majority of this was not statistically significant. We did have some difference in the body mass index, but when it came to EGS diagnoses, there was no difference in the historical and the pandemic cohort. From a disease severity part, some of these components were found to be statistically significant. We found that people in the pandemic cohort had higher temperatures when we marked was over 100.3. They had a either lower or higher white blood cell count, and they also had a higher, lactate level, but the rest, or lower lactate level actually, sorry, and the rest of them we didn't see any difference from those standpoints. And then finally, when we brought it across the grade, when we looked at the ASDT grades by ICD diagnosis, there was no difference in grade 1 through 5. Now, not all of them have 5 categories, but we didn't see any difference in that or in the complexity. So if you turn down now, we looked at kind of management, and this is kind of our, I think the most important data we pulled from our organization and our research was the facility type and the acute care hospital size that took care of these patients. Now the numbers and percentages are not way off, but they are statistically significant, that more patients in the pandemic cohort were able to be managed by hospitals with less than 200 beds, as opposed to beds that were over 500. Now we did have an increase, obviously, but we did see that increase in the lower beds. And we also had an increase in the people that were able to be managed at urgent cares and freestanding EDs, and happy to kind of discuss those kind of things in the discussion part about how we kind of managed that thing as a team. And then when it came to surgical management here, some of these kind of go off the board. The only thing that was statistically significant is the length of surgery, especially in the 1 to 3 hours was seen. I'm not sure exactly what that kind of correlates to, but that was the only category that had a big increase. We had less surgeries that took a shorter amount of time. But that 1 to 3 hour definitely saw a significant increase in those. If you look at our outcomes from the pandemic cohort to the historical cohort, the 30-day mortality was decreased in the pandemic cohort, but also we noticed an increase in the 30-day readmission. In my personal opinion, I think we'd operate on people as quickly as we could, get them out of the hospital, and then maybe because of that, some people would bounce back as we were fighting to struggle to keep beds open. And these were statistically significant once we controlled for all the bottom variables. This right here, just another regression here. We looked at this and we saw decreased ICU utilization between peak 1 and peak 2, and then peak 3. So we looked at how these people were managed. Are we using the ICU beds? Are we using more ventilators? And you can see that our ICU utilization went down. Our ventilator management went down. I think this has a lot to do with as the COVID diagnosis and the COVID management changed in the medicine side. It also kind of affected the surgery side. As we talked about, our 30-day readmission was higher in the peak 3 than the other peaks, but we did have a lower mortality at that time. So if you kind of look at our conclusions based on our hypothesis, these are our major ones, and we'll discuss, I think, the most important one at the end. So the volume of EGS period did decrease during the first and the second month of the pandemic period. We didn't see as sharp of an increase or decrease on the third one. From a disease severity, there was not a rebound that we'd expect. All these people would be sitting at home with severe gallbladder disease when they came back after a pandemic, and we didn't see that significant increase in those. The socioeconomic impact was actually the opposite of what we thought it was going to show. It showed that people that had a higher percentage of patients in the highest income categories were the ones that admitted to the hospital, and we expected the opposite. For patient outcomes, the rates of surgical intervention, ICU usage, ventilator usage, and length of stay were similar in the pre-pandemic and pandemic periods. Now, they were different in between that peak 1 and 2 group versus the peak 3 group. And I think kind of the most important part from this paper is that from a patient volume and distribution standpoint, more patients would be able to be managed at freestanding EDs. They're managed to be managed at the smaller hospitals and during the pandemic. Obviously, this is just limited to our area, which is the greater Charlotte area. But we kind of agree that we would like to continue our research and looking at this and further management of EGS patients for optimization of healthcare utilization, especially across the metro area. So I'll take any questions if anyone has any from that standpoint.